So welcome everybody. I would like to acknowledge the people of the Kulin Nation, who are the traditional custodians of the land that we are meeting on today. I would also like to pay my respects to any Aboriginal people who are joining us today. Slide. I'd like to acknowledge our speakers, Professor Stephen O'Leary and Raoul Wills, who have generously donated their time and expertise to provide this presentation. I'd also like to thank the North Melbourne Primary Healthcare Network for partnering with us to provide this GP education event. We're also very grateful to the Cochlear Fund, who have generously donated a grant to assist us to fund our GP education program. 2 slides, please.
Are you still there? We might have lost Lena, do you think?
Yes, I believe we have. That's all right. I'll step in for, oh, here she is. She's back now.
Right. You've got your housekeeping, haven't you? Right, yeah. Lena, you're muted at the moment.
Apologies, my internet just dropped out. I might just quickly do the housekeeping. I have some other slides to show you about health pathways and our website. I'm going to skip all those and go straight to our speakers. I might come back at the end if there is time and hope that my internet's better. Feel free to ask questions as we go. None of the audience, you'll notice that you don't have cameras or microphones, so they're all turned off. So if you want to ask questions, you'll need to type them into the Q&A box. I'll be moderating the questions. If you have any technical questions or difficulties, please type those into the chat section, and Claire from the Northwest Melbourne PHN will be supporting us and monitoring those. We are video recording this event. I'm just going to skip over the clinic information. Most of that will be covered by our speakers anyway. Health pathway. We'll come back to learning objectives we're all aware of. And it now gives me great pleasure to introduce our first speaker, Professor Stephen O'Leary. Professor O'Leary holds the chair of Otolaryngology at the University of Melbourne. He obtained his PhD at the University of Melbourne under the mentorship of Professor Graham Clark in 1994 and completed surgical training in ear, nose and throat, head and neck surgery in 1998. He has worked as both a medical researcher and a surgeon at the University of Melbourne and the Royal Victorian Eye and Ear Hospital since 1999 and holds an honorary appointment with the Bionics Institute. Professor O'Leary is recognised internationally for his clinical and research activities in ear disease, hearing and balance, and particularly for contributions to cochlear implantation and the protection and regeneration of the inner ear. Professor O'Leary dedicates his time to both research into otology and surgical practice. He was elected Fellow of the Australian Academy of Health and Medical Sciences in 2017. Okay.
And
I'll hand over to Stephen.
Okay, thanks so much, Lena. And let me just get my screen sharing going here. And then hopefully we can get the slideshow on the road. Anyway, look, it's a great pleasure to be asked to give this talk. We're talking about something that's preoccupied my entire life. It's no doubt the most satisfying thing that I do clinically. It's not just the restoring of the hearing. The patient stories are really important, but it's also the team, and you'll meet Raoul later, who's part of the team. It's a very special kind of clinic to work in, where we all work and have such clearly defined roles in ways that I think health generally could learn a lot from. But anyway, we're here, I trust, to bring you into a better understanding of cochlear implantation and really hearing loss more generally, and where and when we should use some of the options available to us. So what we're going to cover tonight is identifying those who need our help, our meaning the Cochlear Implant Clinic's help. Really pivotal to understanding all of this is why we need 2 ears to hear in the first place. I'm going to talk to you about how age is not a barrier. We treat very, very young and really very, very old people, and everyone has a right to hear, and it improves the quality of life, particularly for the extremes of life, you might argue. There are certain red flags that should urge urgent referral, and these patients may come your way. So it's just worth knowing what you really should not wait at all to argue. They're going to talk briefly about single-sided deafness, and that's an introduction really to the treatment options that we have available. And that will segue into Raoul's talk, which is a little more detail about the rehabilitation side of things, which is, you might say, the implementation of some of these devices, of which, of course, cochlear implant is one, but not the only thing we consider when we see a patient with hearing loss. And finally, just a little bit of a comment on emerging technologies, which is always a really fun thing to do. So what is the cochlear implant? Well, I'm not going to tell you lots about it, but I'll tell you the basics. The cochlear implant is a device that introduces electrodes into the cochlea or into the inner ear. The reason why, and then these are electrically stimulated in a way that sends meaningful hearing signals to the brain. The control center is a thing that looks a bit like a hearing aid. It actually takes in the sound through a microphone or several microphones. It processes the sound in a way that the brain will understand, transmits that information across the skin. So there's no actual communication across, there's no physical thing binding the inside and the outside device to the inside device. And the inside device has a receiving coil. It also gets its energy to run via this external coil, and it sends and programs these electrical impulses to different places along the cochlea. The thing to appreciate about the cochlea and why this whole thing works is that the auditory nerve is stretched out along the entire length of the cochlea. The high frequency sounds are perceived at the basal end of the cochlea and the low frequency sounds at the top. So if you electrically stimulate different parts along the cochlea, you will succeed in stimulating different sets of nerves, and the sounds are different. And that is how we get different sounds from a cochlear implant. No more on the physiology. I don't think it's really necessary. But what is the main indication for a cochlear implant in the first place? It's clarity, not loudness of speech. What we find is that most people who receive a cochlear implant can still hear something. In fact, with the hearing aids up, they may actually hear quite loudly, even sometimes uncomfortably loudly. But what they lack, and why the implant was invented by Graham Clark, was because they don't have clarity to the speech that they are hearing. We'll come back to that. But the other major thing to introduce early is this concept of acquired hearing loss and prelingual hearing loss. And what is the difference? Well, acquired hearing loss is hearing loss that begins after you have learned to speak. Prelingual hearing loss, as the name suggests, is hearing loss that occurs before you have had a voice, using your tongue. You will no doubt know from life's experience that children begin to articulate their first words at around 1 year or to 14 months, but they're actually listening much earlier than that. They're starting to pick up on the fact that what people are saying around them is actually meaningful and has a context, from the minute they're born, and some people argue even in utero. And if you haven't learned to speak by the time you're about 3, then the ability to speak diminishes considerably. And by about the time you're 5, you're never going to learn to speak. And pivotal to this is being able to hear during these periods of time. So it's a very, very important distinction about whether someone's hearing loss was acquired, meaning it occurred after the onset of hearing loss, or it occurred prelingually, before the onset of someone learning to speak. So there's a subtle distinction here that you may hear from time to time, but it's really worth adding a little bit of meat to, and that is this idea of congenital hearing loss and prelingual hearing loss. They're not necessarily the same thing. Congenital hearing loss means that it's something you've been born with, but it may have been very, very mild when you were born. And how severe it is before a child has learned to speak is what determines whether this becomes a prelingual hearing loss or not. We see children who have maybe had a very mild hearing loss at birth. It's not even detected perhaps, but we think it's been there since the very early days. But, you know, it doesn't really become significant to the patient until maybe a few years after they've been born, and when they've substantially learned how to listen and understand that what they're hearing is speech and to learn is language, and to learn to speak themselves. Just another thing worth saying is you've probably heard of hereditary hearing loss. Well, hereditary hearing loss is something you've inherited through your genes. It may, of course, be a congenital hearing loss. It may lead to either an acquired or a prelingual hearing loss. So that's all on definitions. Now let's move to how we assess people who might need a cochlear implant. And this is perhaps the most important slide in the talk. I actually ask these questions whenever I see a patient who is saying they're struggling with the hearing aids and that they really can't cope anymore. Because when I've asked these questions, I've got a fair idea about whether they're going to need cochlear implant assessment. And sometimes I even know whether they're going to end up with an implant, believe it or not. And the first thing is the patient wearing properly fitted hearing aids? Is a really important question, because really all bets are off until then. And if they are wearing their hearing aids, how long is it they've been becoming socially isolated? Because people who are no longer able to hear with the hearing aids inevitably end up with a very significant social isolation. And it's this that's going to bother them. So they'll talk about becoming, no longer going out to social events, not wanting to go to dinner, no longer wanting to go to their religious place of worship, or these kinds of everyday things that really are the richness of life. And this is what makes them very upset. And then to judge how severe the hearing loss is, I ask people whether they can use a telephone. The person who cannot use the phone is a good chance they're going to end up with a cochlear implant. And usually hand in hand with that is the patient says, look, even when I'm wearing my hearing aid, I still cannot understand the TV. So these questions tell you just about everything you need to know about whether someone should have a cochlear implant assessment. The other question, which is relevant, is whether this was a congenital loss or an acquired loss, because a congenital loss or a prelingual loss obviously means that their ability to use hearing for speech is going to be diminished to some extent, unless it was rehabilitated very effectively very early. But those questions about the TV and the telephone, if you take nothing more away from this talk, I would use these in my daily practice, as I have done with every patient I've seen for the last 20 years. The next question is, well, what's the relevance of the audiogram in all of this? I think it's worth looking at these audiograms, because on the left, the patient, both those patients' ears, the left audiogram, both the patient's ears fit our cochlear implant criterion. On the right, the left one is meeting the criterion, but the right one is not. Is there really much difference between these? Not much to my eye. And, you know, we talked about mild, moderate, severe, and profound hearing loss, and this is a very helpful concept. But it doesn't tell the whole story. It doesn't tell the story about whether someone with an appropriately fitted hearing aid can actually use that hearing aid or not. And we know that there are severe limitations to relying upon audiometry. We know that speech perception, or the ability to understand speech, can vary markedly for people with the same audiometric threshold as I've just shown you. And that this audiogram is nothing more than a ballpark. So we need to rely upon speech perception testing as a gold standard for working out whether someone's hearing, and actually it's really more than just cochlear implants, but we use it routinely for implants, is actually adequate for their needs, and whether we can do any better. And look, it's just interesting, I think, to, oh yes, so why is this? Well, it's because different cochlear pathologies can give the same audiogram, but depending upon what is still functioning in the inner ear and what's been lost, it can lead to a very different speech outcome. And I want to just give you an example of this. This is a picture that illustrates what Charlie Lieberman brought to attention in 2009, which is sometimes called colloquially hidden hearing loss. You've probably heard of it. But if you haven't, it doesn't really matter. What is important to understand here is what we're looking at the top is the sensory cells of the inner ear. These are the inner hair cells, this row that I think you can probably see my little pointer there. It's this nerve that detects the movements of the basilar membrane, and it's this nerve that is connected to the neurons that send the signals to the brain in normal hearing, obviously not in the cochlear implant. Just for your information, these outer hair cells are actually cells that move, and they move as fast as sound is vibrating. And what they do is something quite extraordinary. They take the passive movement of the basilar membrane and they amplify it. And when they amplify it, what it means is the sounds become, you can detect much, much lower intensity sounds. And it also means that you detect sounds over a very small part of the cochlea. Without these hair cells, what you're hearing is a big, broad noise. With these hair cells, you can hear extremely soft sounds from an extremely narrow part of the inner ear. But anyway, what I want to talk to you about is synaptopathy. This is a thinning out of the nerve connections that go to the brain from the inner hair cells. And you'll see here, there are lots of these nerve connections, and here there are very few. Now, synaptopathy is something happening to everyone, actually. A person of the age of about 50, unfortunately, has only about half their neurons still connected to their hair cells. And if you understand this, you begin to understand why it is that when you get to a certain age, and an age that you think might be still very much in the prime of life, you're struggling like everyone else around you to hear in a noisy situation. This is the reason. And of course, it may be more severe, and if there's been noise exposure, for example, even noise exposure that doesn't change the audiogram, we know that people are getting a thinning out of the auditory neurons, and that is causing people difficulties in hearing. Firstly, the important thing to say is this does not affect the threshold you can hear at. You can get away with hearing the soft sound with a lot less neurons than what you started off with. But it has a huge effect on listening in the presence of background noise, essentially listening to any sound that is supra threshold, or it means it's well above detection. So you can see, even with this simple example, you can have things going on in your ear and everyone else's ear that really will affect our ability to hear in the presence of background noise, that has no effect at all on the audiogram. So that's the general idea. Audiograms detect threshold. It's a simple task of detecting a soft sound, but you will listen at super threshold levels, which explains entirely why it is that you can't understand, say, speech in a noisy situation when you get to a certain age. And just imagine this combined with cochlear pathology, and you begin to understand why the audiogram isn't the basis for understanding and deciding upon whether someone needs a cochlear implant. So the next thing to do is to bring in a new concept, and that is listening in noise and why we have two ears. Well, we have two ears for this one and simple reason. That is that the sounds are different that reach the ear. So this, if the speaker is near this person's left ear, then the sound will arrive earlier and it will be louder than it does when it reaches the right ear. And the body can use these cues to work out where the sound is coming from. Now, that's a really useful thing. If there's, say, several sounds you might have in your environment, one of which is the important one to you. If you can work out which one's important to you, you can attend to it, you can look at it, or you can also pay attention to it. So you can't do this with one ear. And that's why people that have a sudden hearing loss in one ear suffer so much. They struggle so much to hear in the presence of background noise. And it can be entirely debilitating for very young people because all of a sudden they can't work out where the sound's coming from. So, you know, this, of course, a related concept is that of attention and localization. So that if there's, say, a speaker and there's a sound, it might be music you want to listen to, but it may not be. You probably want to listen to the speaker. You can attend which of the, you can actually choose which of these to attend to if you can work out where the sound is in your auditory space. In other words, if you can localize sound. So I think a really interesting idea or analogy is vision. You'll know from experience that if you are looking at something, what's in your visual periphery is usually not visible to you. And what that means is that it's not that it's not there, it's just you're not paying attention to it. And we pay attention to hardly so little of what we see, it's not funny. The same thing is happening with sound. And you can think about sound as a three-dimensional space. And we're using our two ears to work out where in that three-dimensional space the thing we want to listen to is. So you can't do that with one ear. And there's yet another problem about having one ear, which is very distressing for those people concerned. I'm giving you here the concept of a head shadow, and it's literally that. So here we have a speaker next to a right ear, and clearly the head itself is, in a sense, shielding the left ear from that speaker. And we call this a head shadow. And look, the head shadow, much of the time, probably doesn't matter if you've got two ears, really, because you've got all your other cues and all those other ways of working out where somewhere a sound is in space and attending to it. But let's now say, for example, your right ear is deaf. If your right ear is deaf and the speaker is near your right ear, you've got a problem because you've got a head shadow that is causing difficulty in you hearing and making it more difficult for you to hear someone who's on your deaf ear. And now let's just add in a bit of noise. If you bring in a noise near the good ear, the left ear, then people really, really struggle. So that's been a really quick tour through why it is you have two ears, but it becomes really important when you've got the patient in front of you. And you've no doubt all seen patients with sudden hearing loss. And just reflect maybe next time you see a patient, a young person who's lost their hearing in one ear, what kind of trouble they're having. And think, just imagine what it's like when both ears are bad, okay? And this is why the principle upon which we work is to get both ears hearing as well as they can. And in some sense, it doesn't matter to us at the implant clinic how we do that. We use all methods available, but this is the aim, and these are the reasons. So what have we learned so far? An audiogram isn't enough, that you need two ears to localize sounds so that you can attend to sound, and that the head shadow is a real problem with single-side deafness, especially in noise, and that we've learned that clinical history gives a better impression than any audiometry until you do something quite sophisticated on how a person is coping with their hearing. And finally, speech perception testing is required in order to determine whether someone needs further intervention, such as a cochlear implant. So I keep talking about speech perception testing, and what is it? Well, it is listening and repeating back words or segments of words. We call those phonemes. They're the kind of smallest useful bit of a word, like bat, cat, mat. They're all phonemes. But catnap is 2 phonemes. That makes sense. We tend to like to use phonemes at the Cochlear Implant Clinic because it's a really sensitive way of testing how well someone can hear, or whole sentences. So people hear speech, they repeat it back with or without lip reading, because some people we see can't do this without lip reading. And we want to know how well they're lip reading, and that gives us an idea about how they're functioning in the real world, as particularly when they can't do this at all with their natural hearing. We are interested, for all the reasons we've discussed, in how people do this in quiet situations and also background noise. And we do it in each ear and together. And so we do it with the patient's best hearing aids, their best aided condition, we call it. So you can see we are trying to emulate people hearing with 2 ears in as natural an environments as we can muster in a clinic situation, listening to the things that really matter to them, which is speech. And it's this that we use to determine whether someone needs a cochlear implant. So what do we do with those scores? Before we get to the graph, I just want to draw your attention to the bottom of the slide, where the crunch is that the benchmark upon determining whether someone might need a cochlear implant is to compare them to average cochlear implant performance on these speech perception tests. We'll see some examples here where I've marked on this graph from our clinic experience with large numbers are the word scores that people tend to get when they come to our clinic. Most people with normal hearing will get up near 100%, but of course we're not seeing normal hearing people. The median score is about 46% with a cochlear implant, and the first quartile is about 26%. So, we can say, if you've got a word score, but we'll move on to the phonemes because this is what we actually use, right? The median score with phonemes, the cat-bat kind of scenario, is 71%, is how well people do after the cochlear implant. And the first quartile is at 55%. So that means that 75% of people are doing better than that. Now, it means if someone comes to our clinic, they've got their best hearing aids on and they're getting 30%, we know that there's probably a 90% chance that they will do better with a cochlear implant, all else being equal. If they're at 55%, we know there's a 75% chance that they will do better with the cochlear implant. If they're getting around 70%, the chances are they may not be much better at all. Some other things need to be considered with this. So that's how we use the speech perception testing in the implant clinic. But we also do this in noise. And the way we look at noise testing these days is a little bit different. What we do is we play noise and speech at the same time. We adapt how much louder the speech needs to be compared to the noise for people to hear. Most normal hearing people can hear a voice that is about 2.5 times quieter than the background noise. Cochlear implant recipients can generally hear when things are about 1.5 to 2.5 times louder than the background noise. And many of our cochlear implant clinics candidates cannot do this test at all, which is why they're struggling in the real world, of course. So that's kind of all the theory, but I trust it's useful to give you a better understanding about hearing, which is just as important about hearing about implants. And what do we do with all this information? And firstly, where can we do this testing? Because you can't get it everywhere. We do it at the Cochlear Implant Clinic as part of our routine. Cochlear has set up with the idea Cochlear care centres to look after our patients. And these are at where you might send someone in the periphery is either to Dandenong, to the Southeastern Cochlear Care Centre, or there's one in Geelong. And as I think Raoul will mention a little more in detail, we've now got some audiologists who have been accredited to join the Ionia Hospital-led Victorian Cochlear Implant Program. And then there are various levels of engagement the audiologists have, and some of them, but all of them will lead to a referral into the Cochlear Implant Clinic ultimately. But some of the audiologists can do the speech perception testing and some of them can't. How do you get this done? If you think a patient might need this speech perception testing after asking those simple questions about that we talked about, and perhaps looking at a hearing test to give it a bit more guidance, you can get it done at the Cochlear Implant Clinic at the Ionia Hospital, of course, and make a direct referral to us. You can refer to any of the Cochlear Implant Clinic's surgeons. They'll be a first port of screening for an opinion and can then make the referrals from there. You can refer to the Cochlear Care Centres in Dandenong or Geelong, or, you know, if your audiologist is comfortable and part of VCIP, you can actually refer to them. So now let's talk about real patients and the kinds of expectations and how we work them up and the considerations for people that might need a cochlear implant. I've talked so far about hearing, as I've implicitly talked about acquired hearing loss and speech perception testing in acquired hearing loss in adults. But of course, some of the people we see are congenitally deaf, meaning that they probably had the hearing loss before the age that they could speak, but we don't know often how bad the hearing loss was when they were learning to speak. So we may find that our expectations of the ability to understand speech is reduced in these patients because the loss may be prelingual. So the key questions that come to our mind, and these are questions worth just bearing in mind for people that you may see, is how does the person communicate? Now, if the person is signing, that's perfectly legitimate. But if they cannot use their hearing, well then, and they are entirely dependent upon signing, we may not be able to help them with a cochlear implant. Well, except for under very special circumstances. The next way you can kind of get a judgment, though, of whether the hearing loss is likely to be prelingual is how clear is their speech. If the person has clear speech, you can be pretty sure the hearing loss is essentially postlingual. And that's really important to understand. The next really, really important question to ask is, have hearing aids helped in the past? Because we see a lot of people with congenital hearing loss and they say, look, you know I have to lip read, but I was doing so much better when I had my hearing aids until a couple of years ago. And now my hearing's dropped and I'm really struggling. That kind of story tells me that this person is going to benefit from a cochlear implant. And they're probably going to do really well with a cochlear implant. And as I said initially, they may not do as well as a person who's got an acquired hearing loss on our objective testing, but they will value what they get back. And that's implicitly the thing. Has your hearing aids changed? Has your ability to use your hearing aids to communicate changed? So look, you know, I've mentioned already perhaps the congenital, what we call nonverbal adult meaning the adult who cannot use sound to communicate and is reliant upon lip reading alone. This means that they definitely have a prelingual hearing loss, and we don't expect them to do well with a cochlear implant. And the things we get asked time and time again is, if I have an implant, will I learn to speak or talk? And the answer is no. Very simply, no. Because unless you have actually had your intervention for a cochlear implant by the time about 5, you're never going to be able to learn to do this. I guess it's not the GP's role to say that, but certainly in terms of counselling appropriately, it's worth GPs knowing that this is likely the advice that the patient will receive from the cochlear implant, because we do want to see these people if they wish to have an opinion. We don't send them away, but it's important that they go with as well-calibrated expectations as is possible. And the second thing, though, and this is a newer field for us, but it's really important, is do they want to, if, you know, understanding they can't understand speech, do they want to hear environmental sounds? And I have had young people come to me, several really interesting stories. One was a young person who in their later teenage years was looking for their independence. And what really upset them was that their parents would open the door of their room simply to communicate with them. And this adolescent had reached a stage where this wasn't acceptable to them anymore, and they wanted a cochlear implant so they could hear that the door was being, their parents wanted to communicate with them. You know, and it's fair enough for a person of that age. The other story I've heard time and time again, which is also equally important, I think, is this kind of idea of a particularly young parents, particularly women, who can't hear their babies cry. And they wanted a cochlear implant so that they can feel that they know when their child needs their attention. Perfectly legitimate. But these are well-calibrated expectations that we will listen to and we will take on board very, very seriously. So I guess you can say from this, just because you can't speak doesn't mean you can't have a cochlear implant. But what you want from the cochlear implant has to be something you can provide. And there are legitimate reasons why this is important. And that brings us, of course, to cochlear implants in children. It's, you know, cochlear implants in children have been an absolute miracle. I can't think of a better word for it, really. To think that a child who was born without hearing, who would never learn to speak, can communicate is an extraordinary thing to watch. And it's a harder assessment, though, and a different assessment. Now, much of the assessment for children is not going to be where you get involved, because often it happens with newborn screening, starts there and works from there through audiological circles and rehabilitation kind of services and case management, and this kind of thing that have been set up through the newborn hearing program. But you may well see these kids come into your practices, so it's kind of worth knowing what journey the parents are on and the child. The major differences between adults and children is that very young children with a hearing loss are, of course, prelingually deaf. It means that they are at risk of not developing oral language and learning to speak. And the other big difference is that objective measures of auditory function. We have various ways of measuring by brainwaves, for use of a better term, whether someone can hear. An auditory brainstem response you've probably heard of. An ASSR, or a steady state response, is another it's actually a midbrain potential. But these can give you an estimate of hearing thresholds. Now, you will have, of course, understood me say earlier that we don't rely upon the audiogram. But we have to be a bit more sophisticated with our assessments in children, because we have to some extent, start with an objective assessment of hearing. And there are some levels of hearing loss where we know the child will be better off with an implant. But then there's a grey area in the middle where they've got, maybe they'll be okay with the hearing aid, maybe they won't. So what do we do then? Well, what we do practically is we give a child with a hearing loss a hearing aid as soon as possible. As soon as they're diagnosed, it can be fitted after newborn screening, and they've been through initial screening, then they've been through diagnostic audiometry. Raoul can tell you more about that. It's a complicated area. But then what we do, which is really pivotal, is we monitor their speech and language acquisition. And if their speech and language, and this is where our speech pathologists come in at the Cochlear Implant Clinic, and it's what makes the implant clinic a really special place, because we have speech pathologists that are embedded in the clinic, whose job it is to assess not just the speech of the child, but their language acquisition, which of course is the basis for all communication. You know, we also do imaging. We do put the child under an anesthetic and check that there is an auditory nerve if we're serious about an implant, or if they've got a totally deaf ear, because some kids with totally deaf ears won't have an auditory nerve. So we have to counsel expectation. And as soon as the child is falling behind their speech and language progression, to a level that our clinical judgment tells us is concerning, then we will offer them a cochlear implant. Which means that for some children who have got profound or very, very severe hearing loss from the youngest age detectable, they'll get their implants as early as 6 months. We're not going to wait for speech and language to develop with those children, because we know they have such a degree of hearing loss. We shouldn't be waiting. But for every other child who's got a less severe hearing loss, we'll wait to see whether with the hearing aids, their speech and language starts to develop along a reasonable trajectory. And here's just a couple of cases to give you a feel for what this looks like in real life. Now, imagine an 18-month-old child diagnosed at the age of 6 months with bilateral profound loss, or severe loss probably. I've already told you profound loss, they'll get an implant. They've got a severe loss. They've worn a hearing aids from the age of 6 months when they were diagnosed, but they've got no speech expression at 18 months. And our speech pathologists are saying, and their language is falling way behind. Well, they'll almost certainly get an implant. Let's take a very different scenario. 4-year-old, got a progressive loss. They've got possibly what we see here, which is a large vestibular aqueduct syndrome, which is this just congenital abnormality of basically the fluid outflow pathways of the inner ear. And, you know, they were diagnosed at 12 months because this is a progressive hearing loss. It kind of starts to get worse when the child starts to fall over and bang their head, and all the brain vibrations get sent like a tsunami into the inner ear and start to deafen the cochlea. But their language is behind and they're not progressing. They've got intelligible speech, but it's a bit unclear. You know, we're likely to think pretty seriously about implanting this child, particularly if their language is falling behind. And here's another, unfortunately, not that uncommon case for us at the idea. 10-year-old child, immigrant, diagnosed at 2 years of age with a profound hearing loss, worn hearing aids in another country since the age of 2, but has no speech expression, meaning they can't speak, and they're using sign language. The outcome, unfortunately, is really sad for these kids because we can't offer them an implant to learn to speak, which is what their parents so desperately want. A few just things about general cases now. General cases, that is firstly the abnormal cochlea. Look, it's not a preclusion to implant. We can implant all kinds of funny shaped cochleas. It's one of the reasons why we do MRI scans and we put the children through this to know what we're in for. Middle ear disease, if you see a child with hearing loss and you know that cochlear implants are being considered, please facilitate as soon as you can to get their glue ear fixed. It's probably worth getting their glue ear fixed through someone who knows about cochlear implants, because where the grommet goes is important in terms of whether we, where we whether we're going to have trouble later with an implant. But you can't make an assessment of a child with glue ear for cochlear implantation because you can't judge their hearing well enough, and you can't judge whether they're going to progress with the hearing loss. Sorry, with the hearing aids. And children with multiple disabilities. These people are fine for implantation, all things considered. What quality of life looks like and what expectations are for a person with disabilities is, of course, calibrated to their level of functioning, but it's all legitimate. And sometimes the only way they're going to communicate with the world in whatever way they will, which may not be speech, is if they can hear. So we look at the whole child and we make a judgment according to need. We err on the side of giving them hearing if we can. Auditory neuropathy is a little bit different. Auditory neuropathy is basically the idea of the auditory nerve not functioning properly. Now, that's a complicated story. I won't go into the details. But as you can probably imagine, with the cochlear implant relying upon stimulation of the auditory nerve, if the auditory nerve isn't working properly, that's a bit of a concern. And indeed it is. More than half the kids with auditory neuropathy, the problem with their auditory nerve is somewhere a bit further closer to the sensory cell, and they do fine with implants. But if they've got a true neuropathy and the nerve is not functioning properly, they may not do so well with an implant. And we just need to be aware of those kids. So, because I've only got about 9 minutes left or 8 minutes left, I better move on. I want to tell you the story of Dulcie. It's a really pertinent story. Dulcie, as you can see, is having her 100th birthday, and she had it at the idea in my department of otolaryngology. And why was that? Because she came to see me at 98. And Dulcie said, when I was 91, they said you should have a cochlear implant. But I decided that it was not worth putting resources into me. So I said no. But at 98, I'm still doing pretty well. Thank you very much. Still living at home. And she decided it was time. So, you know, we ended up doing an implant on her at 98. And you might say, how could you even think about that? Well, I just wanted to let you know what the thought process is and why it can be done safely. Well, there's a birthday on the left, and on the right, you were seeing a picture of one of our Ionia Hospital anaesthetists, Peter Seal. And Peter is the anaesthetist that spent several months working up the safety proposition for Dulcie to have an anaesthetic. This is a real team effort. It is not done in isolation. And what I do is actually, the first question I ask, is it feasible for this person to have an operation? And I work closely with the anaesthetist. I send people off to the anaesthetist before I really mention seriously implants. And, you know, Peter and I worked this patient up, worked out that they had a really relatively low risk of a general anaesthetic. So we put it to Dulcie and she said, yes, please proceed with the assessments and I'll have it if you think it's going to be good for me. More recently, I've been doing this operation under local anaesthetic. And again, that is a real partnership. The most recent person I did was only a couple of weeks ago. And, you know, he basically, he was determined to have an implant. He was thought not to be fit enough for a general anaesthetic. But with my anaesthetist, we decided that we could get him done under local, which is a real art in its own right. But we managed. And now he's saying he's hearing his grandchildren talk to him for the very first time. The final thing I want to say about operating on people of well-advanced age is that, you know, there are other things that are really important. I mean, we don't deny a hip from someone in their 90s. Why on earth should we deny them communication? Is my way of thinking about it. And even in the last days of life, this ability to communicate with people is so valued by the family. I've had one note from a lady who passed away well into her 90s. I implanted her around 89, 90. And the family were just touched enough to write and thank me that she could hear during her last days. And just think of the quality of that for the whole family. Urgent referrals, meningitis. I expect you won't be the person to have this on your radar. Usually the people are well and truly entrenched with the hospital system, but in case you see a child who's just had meningitis, please ask the question, have you been referred to the Cochlear Implant Clinic? Has that question been raised by your pediatricians or other care team? And if not, maybe just get in touch with us directly, because within a month, the cochlea can completely ossify, and that's what you're looking at in this picture. Ossification means it turns into bone, and we can't do the implant. So we have sometimes weeks to get an implant into these children. So it is really of pivotal importance that the implant is done. The referral is made so we can manage the situation as soon as the child is fit enough, or the person is fit enough to get to us. There are some other really important urgent referrals, and these are loss of hearing in an only hearing ear. These people are now rendered totally deaf, and they will be not coping. We consider this to be a medical emergency. They'll get an implant as soon as we can possibly organise it. So please make sure that you get us a referral urgently under those circumstances. Thanks. There are cases of bilateral sudden sensorineural hearing loss. They need medical management as well as management for their hearing loss. And again, ossification can be an issue with those patients. So please get them to us urgently. And anyone you think may lose their job because of their loss of hearing, or can't work because of their loss of hearing, it's usually a sudden hearing loss. These people similarly are urgent in our eyes. So I'm just going to spend 1 or 2 minutes talking about sudden sensorineural hearing loss. I'm not going to spend much time on the rehabilitation. I don't have time. That's Raoul's going to take you through that. But look, here is a series of questions on the left that I've devised that really reflect what happens when someone loses one ear. I've told you already, it's really debilitating. It can really upset people. But these are the kinds of things that people say. They want to hear on the deaf side. That gets us back to the head shadow discussion. They want to hear in the presence of background noise. They want to hear where sound's coming from. Or they may have tinnitus in the ear. And all of these are factors that we consider when we consider what their options are. So their options are either a cross-aid, which is basically taking sound by a microphone from the bad ear to the good ear. So they're basically we're a hearing aid in each ear. If it's actually a hearing aid in their other ear, that's called a bicross-aid. But the idea is a microphone takes sound from the bad ear to the good ear, or the better ear. We use bone conduction, which is vibrating the bone. And vibrating the bone sends sound from one ear without very little attenuation to the other ear. So it acts a bit like a cross-aid, but you don't have to have a hearing aid in both ears. And the Baha is Cochlear's system for this. And of course, we consider a cochlear implant. Look, I just don't know if it's actually worth going through these slides. I think it's going to confuse you at this stage. There may be some stuff there that Raoul may wish to expand upon. But look, the summary is really, we at the Cochlear Implant Clinic want to get people hearing in 2 ears. Some of the people referred to us just need an operation. They might have far advanced otosclerosis, and we may consider a stapedectomy when it hasn't been thought appropriate earlier. We also want them to have considered hearing aids, and for a single-sided deafness, a cross-aid, before they come to see us, because that's the first thing we'll recommend. And after that, it really depends on the patient's needs and what they are looking for benefit. And we may use either bone conduction or a cochlear implant, or even a cochlear implant together with hearing. In my final seconds, I'm just going to take you through the fact that we're not just providing a service, we are helping to lead the way. We do a lot of the Cochlear's pivotal trials. And one of the pivotal trials we've been doing is on the osseo system. This is a brand new type of bone conduction implant that has a bit that looks like and essentially functions kind of like a cochlear implant, except that it's vibrating actual sound vibrations into the bone via this little screw. And the person wears an outside bit that looks a bit like a button type of a cochlear implant. We've done some of the first trials in the world with this in Melbourne. And finally, Raoul talked about the barriers to referral. One of the major barriers to referral is the loss of the fear of losing residual hearing. And my pet topic for the last 20 years, just about, or 15 years more like it, is how to preserve more people's hearing when they have a cochlear implant. If they preserve enough hearing, we can use the implant together with the hearing aid. That's called electroacoustic hearing. People, though, will have sound awareness, even when they've not got the implant on, which they value. And finally, as surgeons, we use it as a barometer of how well we're operating. And if we can preserve the hearing, we know we've done very, very little damage to the inner ear by the operation procedure. So, you know, my team has invented intraoperative monitoring for hearing aid directly through the cochlear implant. We basically turn the cochlear implant on and we use it as a recording device where we play sounds into the ear. It's been adopted by Cochlear and is now global research software that is distributed both through the FDA in Europe and in Europe by Cochlear. I'm just going to show you how it works. What you're seeing here is sounds being played into the ear, and this is an actual cochlear implant going into the ear. Up here we see the signal that is generated, and as we go deeper into the inner ear, we expect that signal to grow if that electrode is being put in a way that is not damaging the hearing. And when we can manage that, hearing preservation is improved, so that when that signal, which you'll see is not dropping, the no drop group, you'll see that there is less hearing loss, which means you're further down the bottom of the graphs here than when that signal is lost. So, you know, we'd like to, well, we know we are at the forefront, not just of providing advice on clinical management, but also on making this device better for patients in the future. And with that, I'd like to thank you for your attention.
Thanks so much, Stephen. That's very exciting. You must be so proud, and I guess we're all proud that this is Australian technology. That's a very interesting presentation. I don't see any questions at this stage, so I might proceed. You're going to hang around for Raoul's presentation, are you?
Oh yes, yes, of course. I'm here for the you know, I think we're a team.
The duration.
Yeah.
Okay, right. So if there are any questions, we can come back at the end. So thank you so much, Stephen. I think that was really enlightening and interesting, and most of us probably learnt so much from your presentation that we really didn't completely understand before. And I think is really useful as GPs to know that, to help guide our patients, and in terms of what to expect and whether they will be suitable candidates. It now gives me great pleasure to introduce our second speaker, Raoul Wills. Raoul has been an audiologist at the Cochlear Implant Clinic since graduating from the University of Melbourne in 2015. Raoul specialises in adult rehabilitation and teleaudiology. With a background in linguistics and multimedia, Raoul has a keen interest in developing new ways for patients and clinicians to engage and work towards improved hearing outcomes. Raoul enjoys playing ice hockey through the local rinks in Melbourne and building computers in his spare time. I guess doing a lot of computer building recently and not ice hockey with the lockdowns.
Yes,
Thanks,
that's right. I just actually wanted to touch on, we did have a question from Susan. Just Stephen, you might be able to give some insight into this regarding when the osseo may be approved and released in Australia.
I just answered it. Okay.
Oh, in the text. Okay, yes, sorry.
Yeah, I mean, look, I won't take your time. You can read it in the text.
Sure. I'll get started. Okay. Can everyone see my slides okay?
Yes. Yes.
Okay. All right. What I'd like to do is talk a little bit, this will be touching on what Stephen has already presented, but there'll be some more detail or some different detail as well. And what we've been working on at the Cochlear Implant in the past year, where we've had lots of time sort of trapped in the office to get things done, is to try and improve the access to cochlear implants throughout Victoria. So we mentioned the Victorian Cochlear Implant program, and I'm going to go over that in the next slide. We have the pathways for traditional cochlear implant patients who are referred to us. So these are generally the adults who have had their hearing decline over the years, and they're now struggling to a significant degree, often ending up with profound hearing loss by the time we see them. We look at these candidates who may sometimes end up with 2 cochlear implants if both ears are bad enough, but also patients who are finding new ways and new technologies that assist them to hear with a cochlear implant and a conventional hearing aid in their other ear. We're also looking at expanding the sort of patients that we go ahead with for cochlear implants. And these are patients who have what we call steeply sloping hearing losses, where they may have areas of quite good hearing, but also parts of their hearing that is very damaged. And it makes it very hard for them to hear clearly or reliably, even with hearing aids. There's also the group of adults or younger patients who come to us with single-sided deafness or unilateral hearing losses. And this is where they've lost usually all hearing in one ear. And this can happen almost overnight or, very rapidly. And it can be quite distressing for these patients that we see trying to cope with the sudden loss of hearing from one side. I'll talk a little bit about bone-anchored hearing aids as well and how these factor into different sorts of hearing losses. So the Victorian Cochlear Implant program is something that we've been rolling out as a pilot in May this year, so it was recently launched, but there was a lot of work in the background in the year leading up to this. And so what we have now is, instead of having a fairly centralized system in Victoria, we've onboarded a number of keen audiologists in and around Victoria who have been trained up and have been working with mentors to offer the level of sort of testing and counselling and even post-operative rehabilitation that previously was only found in Melbourne or around Melbourne. So we have clinics up in Albury who have visiting sites and a clinic out in Ballarat and in Gippsland as well now. And we also have the old cochlear care centres in Dandenong and Geelong, as Stephen outlined. So this is our big focus at the moment, to really get better access locally so that the trip to Melbourne isn't a necessity anymore. And we've had a lot of enthusiasm from these audiologists and the communities around them about this change that we've recently rolled out. One of the reasons we wanted to do this is because we found that our service alone wasn't able to really provide access to enough people around the state. And we even have patients visiting from over the borders where we're still the closest hospital to them that can offer cochlear implants. I won't go too much into depth about our team. Stephen's already covered that in detail, but just looking at the sort of numbers we generally were seeing I'll go for 2019 because it was more of a normal year, but we're doing over 300 implants a year. We had recently seen our 5,000th implant recipient. And so we're really having a sort of a broad range and a wealth of knowledge and expertise in the area. We see both public and private patients, and we offer them ongoing care and ways to look after their implant systems in the many, many years and decades after they've received them. So one thing that we're working hard to try and improve is the current situation where the majority of people, the vast, vast majority of people who could benefit from a cochlear implant do not have access to one, or they haven't been referred for one, or they simply just don't know that they would be a candidate, and that there would be a reasonable possibility that they would improve their hearing significantly over the sort of level it is currently in the future with a cochlear implant. And so we're almost seeing that, you know, only about 10% or so of adults who could benefit from a cochlear implant currently have been involved in a system where they can receive one. So it means there's a lot of people out there that are living with quite debilitating hearing loss. You know, it's not just a little bit of hearing loss where a hearing aid is still towing the line, a hearing aid is still getting them through day to day, and they're not withdrawing from social interactions. We're talking about people who are completely removed from most conversations now, and any sort of family gatherings or group situations, they're likely to be avoiding those. So we really want to try and change this situation around, because it's a bit of a concern worldwide about how little is being successfully done about it. One of the things we've looked at, and this is really from our sort of a survey from our two main sources of referrals. So our two main sources of referrals are GPs and community audiologists. So you are the healthcare professionals that people are often seeing or might start talking about a hearing loss. You might notice a hearing loss a person is struggling with, even if they don't really want to talk about it. And I think Stephen talked in quite good detail about a couple of the main fears or the main barriers for feeling ready to sort of come in for a referral to the cochlear implant clinic, or to consider that option at all. And that is the fear of the surgery itself, and the age a person is when they're, you know, when they often have hearing getting to a degree where a cochlear implant would be worth talking about. And so people will often say, you know, even as early as their 70s, that they're feeling too old to do something like this. But the reality is that if they're already withdrawing from the things that, you know, are the best things to keep involved with for healthy aging, you know, socializing, community, sports and activities, all of these things are harder when you can't hear well. And so we really try and dispel that fear and that concern about age being you know, something that would stop them getting it. It's in fact the opposite. There's really no reason to consider those things as a barrier, especially if they're healthy otherwise, and if they want to be active and want to continue to be active. Also want to just talk about some of the other reasons, because often people will say, I'm making do, or I'm hanging in there with my hearing aid. We don't really want someone to just be struggling day to day, and that's what people will often be doing with severe to profound hearing losses. They'll be exhausted by the end of any social interaction because they're working overtime to piece together all the bits and pieces that they're missing, because they don't have that clarity as their hearing has declined. The distance to travel, and this is a big one, as I've talked about, trying to expand that sort of local access or those local pathways where people can visit someone without having to travel all the way to Melbourne, or sort of feel like they're dislocating themselves to have the procedure done for the sort of 12 months of rehabilitation that we'd expect. I won't go into too much detail again, because I don't want to bump heads with what Stephen's already shown you, but the traditional candidacy is for adults with almost no hearing or very little hearing. We don't always want to wait for this to be the case, where an adult has simply lost all that was left of their hearing, because that's far too far into the decline in their hearing for the cochlear implant to be only just becoming an option. We really want to capture these adults as they're, you know, no longer benefiting significantly from their hearing aids, and those sort of indications of not being able to use the phone, not having the clarity to perform in the sort of environments they want to be able to hear in. That's with hearing aids. If the hearing aids aren't doing that, that's really when you need to start thinking about cochlear implants. And these people will have had it hard in these past couple of years. The removal of lip reading, even just when you go down the shops, because everyone has a mask on, is really hitting a lot of our adult candidates, either with a cochlear implant, or if they're considering a cochlear implant, or if someone out there is thinking that they're not coping with their hearing before, losing visual cues has been massive for a lot of these people. So, you know, it's even worse than it has been in the last couple of years. This is just giving a bit of indication about the actual improvements in clarity and what the averages we see at our clinic are. So this is 1,500 patients that we've seen. And preoperatively, we're measuring with hearing aids on. They come in, the hearing aids are well fit, they're doing the best they can, and we measure how well they can understand a person talking. Their phoneme scores, which is the speech sounds that they're hearing, they're tending to score worse than 20%. So in quiet, with one word presented at a time, they could only guess what less than 20% of being said is, which is nowhere near enough to have any sort of reasonable conversation. And it's no surprise they wouldn't be able to use the phone at all. Getting the entire word right, not even 5% is correct, which is almost just guessing completely. With the cochlear implant, after the first 3 months of wearing it, we see a dramatic difference. So we see that phoneme scores up to 60%, and they're getting, almost half the words now. And so that combined with lip reading and combined with a topic will jump them ahead even further. But just listening alone, they're getting tremendous amounts more information than they were able to beforehand. This can also be combined, obviously, with the hearing in the other ear, which may still be benefiting from a hearing aid. So the combined effect is often greater than this, but this would be cochlear implants alone. It is a long duration rehabilitation. It is a long duration intervention. So it's not something you simply wear for a while and then stop. It's something you'll be wearing and using for the rest of your life to ensure that the hearing continues to be reliable and continue to be a mode in which you can communicate with. So we see further improvements at 12 months, and some adults even improve further at the 2 or 3 year point. We talk a little bit about bilateral implantation or bimodal hearing. So bimodal hearing is when you have say a conventional hearing aid in one ear and a cochlear implant in the other, because 2 ears really do tend to be better than just one. So what people often ask, if I get a cochlear implant, which ear do you do? Do I have to, can I still use my hearing aid afterwards? We tend to focus on the worse hearing ear. If the ears are the same, it's really what the patient uses less conveniently. So if they're using the phone, they're trying to use the phone on one side, preferably, we may do the other side. But if they have a worse performing ear, we tend to try and help the worst ear first with a cochlear implant. And so using the cochlear implant and maintaining the hearing with the hearing aid, even if it is severely damaged on the other side, they don't have to start completely from scratch. They can use some amounts of familiar sound, even if it's very limited, as they adapt to using the cochlear implant. So they build up on this, and it's often the case that the cochlear implant quickly becomes their dominant ear. So the ears swap. Their worst ear that was implanted becomes their strongest ear, even after the first couple of months. If both ears are candidates for cochlear implants, so both ears have hearing severe enough that a cochlear implant could help, we often have people even by the 3 or 6 month point asking when they can have a second cochlear implant because of the improvement they've already gained with the first side. In all of this, technology helps us as well, where we have people now able to stream mobile phone calls or media from their phone and other sort of smart devices directly to both a hearing aid and a cochlea, or to 2 cochlears if that's what a person has. So it can really help give them a richer sound if they're getting sound from both sides, and they can listen to music in this way, take phone calls, do video conferencing, do all the things that we're now using smart devices for on a routine basis. As Stephen highlighted, the preservation of hearing is something that we're really keen to pursue and maximize, because we have people coming in where they have good, deep, low frequency hearing, and they just have very poor access to all the high frequency sounds. They don't hear birds. They don't hear the S's, the THs, the Fs in speech. They miss all of those. They won't hear the smoke alarm go off. They might not hear their phone ringing. And this is because their high frequency information is missing, because their hearing is damaged in this area. And they're missing it in both ears. So they can't get access to certain sounds anymore. Even though the deep, low sounds, the vowels, the tram rumbling down the street, they'll hear that. They hear that well, but they're missing half the picture. The audiograms, one is before the surgery and one is after. And so this patient has received implants in both ears, and in both cases, we preserved the vast majority of their low frequency hearing. So in this case, they have natural hearing and a combination of artificial electronic hearing from the cochlear implants, filling in all those gaps in the high frequencies. Even though their natural hearing underneath remains unchanged, the artificial benefit they get when their cochlear implants are on are dramatic. And these people can, do all the sorts of things that were limiting them before. So they can use the phone. They don't have to struggle. They don't ask everyone to text them. They can participate in group meetings at work and that sort of thing. They can hear birds. They can hear high frequency information. So we have this, and they can still hear without their cochlear implants on. They don't lose what's left of their hearing just because they've proceeded with a cochlear implant. This can also make it a lot easier to get used to, because you're not listening to an artificial sound by itself. You're listening with a combination of natural sound overlaid with additional information from the implants. Looking a little bit about the actual rehabilitation for people with one ear that they've lost their hearing in. So this can sort of be quite distressing because it can happen all of a sudden. And we often have patients coming in to the emergency department who have lost all the hearing in one ear. And unfortunately, this isn't always recoverable, even if we do all the things to try and bring it back. And with one ear missing, localization of sound is always a big one. Picking the direction a sound is coming from, people will often try and find a voice, or where their phone is ringing, they'll just be doing 360s trying to work out where it is. People often will have quite significant tinnitus if they've lost hearing in one ear all of a sudden. And this is something that can be very difficult to cope with in some situations because it's totally unexpected. It's not something they've ever had to deal with before. And these people will tend to do worse in group situations. They'll want everyone sitting on their good side, and that's not always possible. You don't always get to pick and choose where you're sitting, and not everyone's going to make it easy for you. So there's certainly a lot of instances where these people suddenly feel like they've lost a lot of, their functionality. I just want to look at the results for sort of a young man who I saw who had only lost his hearing 5 months before ultimately going ahead with a cochlear implant. So he lost all hearing unexpectedly. He's very enthusiastic to practice and get used to his cochlear as much as possible. This is sometimes a little bit difficult because their good ear will be the dominant hearing ear. It's their natural hearing, and with the cochlear implant being introduced, which can start off slowly or a bit confusingly sometimes, it can take a while for the sound from the cochlear implant to become familiar to a patient. This fellow jumped into it. He quickly was using his phone and his cochlear implant together to stream audiobooks, to stream podcasts, to stream sound directly to his cochlea. So his good ear, his natural hearing ear, couldn't participate. So he was just getting information straight into the cochlea in his own language and in English, which he spoke fluently as well. And so he very quickly got used to what the cochlear implant was doing, and he worked out, his brain was doing all the work to work out what the sounds were meaning, because they're not exactly the same as natural sounds. They do take a little bit of time to get used to. So what was left of his hearing in the ear was down at about 26% in the bad ear. And after the 12 months of practicing, he got up to 91% clarity, which far exceeded the sort of average of 70% that we see for a lot of adults. So he was really an outstanding sort of recipient. He was able to cope with sort of a very significant additional amount of noise. So when he'd previously need a rather sedate environment to hear well in, he could now hear in a far noisier environment than he'd been able to before. And that was instantly achieved just by wearing his cochlear implant. The other thing is looking at his sound localization. He could only really localize sort of a quarter in front of him, looking at sort of it's in front or behind almost, with a very large degree of error. He got that down to 30% accuracy, which is really enough to pick up where most objects are in a room. And that he sort of certainly noticed that made it a lot easier around the house and at work, including, sort of outside traffic, looking for things coming your way or trying to avoid things. You get a much bigger sense of security with that. So he was a very happy chappy after putting all that effort in for 12 months. The other topic I wanted to discuss was changes, and we had a question on this. I know that people are keen, is that we have advances in bone-anchored hearing aids. So whereas previously we would need larger devices to deliver the amount of sound or power that certain recipients would need, this could be recipients with sort of chronic ear infections or problems even wearing conventional hearing aids for risk of further infection. It can be people with single-sided deafness where they're not appropriate or they're not keen on a cochlear implant. They may want to hear more sounds from their bad side in their good ear. Bahas can provide these sorts of improvements. And so we're looking at sort of a sort of technological improvement where instead of a large, overly powered device that needed to be bigger, we're looking at sort of smaller devices which are neater to wear and easier to manage, and also looking at different modes of delivering bone conduction like the osseo, where instead of having the sound generated in a processor outside or worn outside on the head, we have the business then sort of implanted and creating vibrations safely under the skin, where we have less problems with feedback and that sort of thing. So it helps us fit more people with bone-anchored hearing aids. And there's certainly like big technology changes with the osseo coming out. As Stephen answered, I haven't looked what his answer was, so I can't tell you when it is coming out. My last little bit is on some of the telehealth services that we've been running for a few years now. So it's been really great for me to be able to work with the Wangaratta Hospital. And so we did a pilot program where we would be able to map or program cochlear implants, do the adjustments for cochlear implants remotely, so that they'd come into Wangaratta. They would work with one of the nurses that we trained, who were our sort of hands-on with the patient, and we'd be able to chat to them via video call. And this was before video calls were part of every day. So it was a little bit of a learning curve for us about 3 or 4 years ago now. And we've had, numerous patients come through that service where, we can see them in person for part of the journey, and then the rest can be done just down the road for them, or saving a complete, multi-hour trip to and from Melbourne. So it's been a big change for us. And it's been great sort of looking at how the nurses, the staff at Wangaratta and the patients, we're all sort of getting along like a working with like your own clinic. They're just sort of an extension of you now, and you can go back and forth and sort of find ways to help people that you couldn't previously do without the technology implemented. And so we're now able to offer this service with sort of long-term care and checking in on these people. Often something unexpected will come up and we can quickly arrange an appointment locally for them. The recent delivery of VCIP is allowing this to go even further, where instead of having to look at me on a screen like you all are at the moment, you can interact with people who are already, you're under their care already, and who you're already familiar with, your local audiologist, that sort of thing. That's all I've got to share with you at the moment, but I can see the Q&A and chat lighting up, so there's something going on in the background. I might open the floor up to the next bit, which is when we can go back and forth with answers or discussions.
I've been stealing your thunder for half of those questions when I could answer them, Raoul, but there is one for you.
Oh, good.
It was how did this patient lose hearing suddenly?
Yes. So I'll just flick back to him. Okay, so the difficult part is that we call it idiopathic because we often don't truly know why they lost the hearing. In his case, he returned from a flight and he noticed a change in his hearing with tinnitus. We often have symptoms of balance dysfunction at the same time with this. But often, and Stephen, you might want to talk about this, but we don't truly find a smoking gun as to why exactly their hearing has been lost all of a sudden.
Yeah, I mean, like it vacillates between being thought to be primarily viral to vascular. I mean, I think the thing to appreciate is that the inner ear's got one small blood vessel. It's a single blood vessel. It's like the retina. So if you have even a spasm in that blood vessel, you can lose your hearing. Similarly, you can go blind, as I'm sure you're well aware. We certainly know certain viruses can cause it, but the majority of time it's probably vascular, and it's probably just a spasm of that sole blood vessel that does it. But we do MRI scans because we need to exclude other things. And if it's, I think the warning side of a sudden sensory neural hearing loss is two. One is if it's in both ears at once, that could be something very serious neurological. And if it is, the other one would be if it's occurring more than once, it's really not sudden sensory neural hearing loss, it's something else.
I might just interrupt as well, Stephen, just to reiterate about health pathways. Whilst cochlear implants are not covered on the health pathways, Melbourne, at this stage, sudden sensory neural hearing loss, there is a pathway that GPs can follow to assist them to manage those patients. And we do want to see them pretty quickly in case we can give them some treatment.
I think are we out of questions, Sarah?
I'm just looking at the question.
I think I answered most of the ones.
You have answered most of them. I guess for the purpose of the video, perhaps I'll just go back to costs. So patients who are Medicare eligible, it's fully funded under the public health system, isn't it, Stephen?
Yeah, it is. And look, for those with private, I mean, you know, we can't, for ACCC reasons, collude in any way. But I mean, philosophically, we're very against people being charged large amounts of money. I mean, their funds will cover the device and fully. And look, surgeons' practices might vary from anything from no gap to a couple of $100, and you know, we can't dictate that. That's just against the law, as you well know. But philosophically, we're really against patients who have paid for their insurance being out of pocket for this kind of thing.
We had a question just about, Stephen, would we agree with the statement that sensory neural deafness is strongly correlated to dementia?
That's an interesting question, that one. It's certainly an association with, you know, there is a reasonable evidence to suggest that there's an association. And that's, you know, been the Lancet and this kind of thing. What's less clear is whether rehabilitating hearing loss prevents dementia. The thoughts are that it certainly improves cognitive functioning, but that's not quite the same as preventing dementia. So people who are disengaged from the world, who can't communicate with the world, will not function as well. And I think, Raoul, correct me if you have heard anything else, but I think the thought is that if we give someone a cochlear implant, for example, they're just much more engaged, they communicate better, their mental functioning is higher, but it's possibly not fundamentally changing the trajectory of their dementia. Yeah,
so it's certainly difficult to, you know, it's a socializing, I think, is the biggest thing, because a cochlear implant by itself and hearing things, say, around the house doesn't exactly do it. But if you're returning to a very active social life and you're taking part again, well, that's the byproduct of being able to hear better. So we certainly, that's, you know, what we're aiming for ultimately. And giving, you know, removing anyone's barriers to those sorts of things tend to show all sorts of improvements in their general health.
Yeah, it's probably worth just mentioning, Raoul, that there's certainly, I see in the, you know, the private land, you know, the world of GPs and the like, some audiologists do use preventing dementia as a reason for people having hearing aids. Now, I'm not sure what you think about that idea.
I think he sort of mentioned the Lancet study. So the thing there is that, you know, this is in midlife. If someone has the onset of hearing loss, they talk about that you know, it's one of the biggest predictors for dementia later in life. So if hearing loss remains untreated, it's sort of contributing more than even someone being obese, for instance, or alcohol consumption. You know, those things are 1% and 2%, whereas hearing loss is up at 8% as a indication for later risks of dementia. So I think that's where a lot of jumping up and down as to why should you wear your hearing aids or get them in the first place. And so it's really, if hearing loss goes untreated for decades, we start to see potentially fairly significant downsides to that later in life.
Let's look at the Q&A here. I mean, there's one question. Can referrals be made from GPs to any private clinics in Melbourne? Look, we run a statewide service. Many of the surgeons, and most of the surgeons, will have a private practice, and sometimes patients come in via their private practices. And if you have a relationship with one of the surgeons who are part of our team, you may be more comfortable to send the patient there as the first port of call, and they'll know what to do. They'll get the patient into the system and can facilitate their treatment. But look, it's fine to send them directly to the Cochlear Implant Clinic. We have patients going both ways. But there's no separate private clinic. Again, we've tried to avoid that because we've strongly based our practice on evidence and on quality. And it's pretty clear to me and everyone else involved that you get quality by actually having a good sized practice with a huge corporate knowledge. Every week we discuss every patient with all the audiologists, speech pathologists, and people from the cochlear care centres and some VCIP partners in the same room. And if we had small private clinics, well, it's not going to achieve that. It never can.
We have a question here about hearing protection and whether, other than standard hearing protection for noise, is there any precautions or exercises that someone can do to reduce the incidence or the degree of their sensorineural hearing losses? I think obviously hearing protection is a big thing, and it's certainly nice to see that in industry it's taken very seriously nowadays, whereas a lot of the older patients that we see, it wasn't taken seriously during their working lives. So certainly it helps us that most industries are certainly on board with that. As far as exercises or preventative measures, general good health, as far as those, I don't know if you'd suggest anything other than that, Stephen, for the secret to preserving your hearing?
No, look, I mean, there's been all kinds of studies about using, there are people that have tried to look at vitamin combinations and this kind of thing, but it's not in the realm of validated science. I mean, I think the idea of keeping people as healthy as possible will help all domains of their life. GPs know better than most. So at this stage, there's nothing proven or shown, you might say.
It's Lena. I'm going to interrupt just for a moment. Thank you so much. I wanted to add to the panel discussion a couple of points. One is one of our other fabulous otolaryngologists at the Eye Hospital, Dr. Jean-Marc Gerard, did a webinar for us last year on the exact topic of hearing loss and cognitive impairment. So those who do have an interest can go onto our GP education page of our website and watch a recording of that webinar. I also wanted to make a point that GPs referring to the Cochlear Implant Clinic to note that it is an MBS funded clinic, and therefore the referrals need to be to either a named specialist or to at least say, dear otolaryngologist. We do have a specific form on our website that obviously makes the process easier for us if you use that form. I'm not even going to show you where it is because our website is changing, and so it's probably going to move. But my recommendation is if you just go into the search box and type in Cochlear Implant Clinic referral form, you'll find it. There's also other information there, including most of what was covered tonight about those who are good candidates. And that particular information, I will just point out, is not with our other referrals information at the moment. So I'm sorry that that's a little bit tricky, but the website will be upgraded soon. So hopefully we can have it a bit better organised. I think they were the main points, except to say Claire has posted a link to the feedback survey. If all of our participants could go online and fill that in as soon as we close the webinar, that would be fantastic. We do value that feedback. We do need it in order to allocate your RACGP points. And we use it just for our own quality monitoring. There was one final question we didn't answer, and that was, what sort of waiting time do we have at the Cochlear Implant Clinic for GPs referring in?
It's been something we've tried hard, isn't it, Raoul? I mean, you can answer it. I mean, and of course, COVID has hit us from time to time, but
yeah, we generally try, and so if it's a new patient, we're generally trying to really get that sort of wait to hear back from us and have an initial discussion. So I sort of wanted to highlight that, you know, you're not booked in to have an implant. Patients often come sometimes with their toiletries because they think they're staying the night in hospital, but we're really having a chat and just introducing the concept to them, and, you know, looking at them as an individual. And so we usually try and do that within 10 weeks and certainly closer to 5 weeks. But we do get thrown around a little bit with, you know, the plug getting pulled on everyone coming in or back to normal. And so it has been one of the focuses. But the people who come and see us, they're generally getting a surgery within 6 months from when they're referred. And once they're on the hospital waiting list, it's usually about 3 months, although that is a bit rocky at the moment, again, with the nature of lockdown and that sort of thing.
Thank you. Okay, we have actually gone 7 minutes over time, which is awesome. That means it was very engaging and there were lots of questions at the end. And certainly I'd like to, I'm very grateful to both of our gentlemen speakers who both presented really interesting and informative presentations tonight. Please, participants, click the link to do our evaluation survey. Also, if you're not already on my emailing list, then please email me at gpliaison@ioneer.org.au and I'll add you. Other than that, I will mention, yes, we do have a list of video recordings from previous events on our GP Education webpage. And this event, it has been recorded, and I will email my list when that recording becomes available for those who want to watch it again or pass it on to friends. Thank you to our speakers, Professor Stephen O'Leary and Raoul Wills, for fabulous presentations, and thanks also to Claire from the Northwestern Melbourne PHN for all of her support in bringing this webinar, and to the PHN for all of their ongoing support of our GP Education program.